Okay, let's dive right into this comprehensive pathology board review explainer. We're doing rapid-fire clinical MCQs today, so let's skip the preamble and get straight to the cases. Starting off with question 16. Which of the following statements is actually true concerning inherited germline BRCA mutations? Is it A, 15% of all breast cancers diagnosed annually are caused by BRCA mutations? B, BRCA mutations play a fundamental role in cell cycle control and DNA damage repair pathways? C, male BRCA2 mutation carriers have an equal risk of developing breast cancer compared to non-carrier males? Or D, 100% of women with a BRCA mutation have inherited it exclusively from their mothers? So, the crucial point here is that the correct answer is B. BRCA genes basically code for these really critical nuclear proteins that are involved in tumor suppression, cell cycle checkpoints, and fixing double-stranded DNA damage. Now, because it's inherited in an autosomal dominant fashion, 50% of women with a BRCA mutation actually inherit it from their fathers, which completely rules out option D. Also, male BRCA2 carriers face a 6% lifetime risk of breast cancer. To put that into perspective, that is a 100-fold increase over the general male population. All right, moving right along to question 17. Standard therapeutic management pathways for early-stage invasive breast cancer include all of the following except A, total mastectomy with axillary staging, B, neoadjuvant systemic chemotherapy combined with concurrent radiation as a definitive alternative to surgery, C, lumpectomy with axillary staging and postoperative whole breast radiation, or D, total mastectomy with axillary staging and immediate autologous or prosthetic reconstruction. And the exception here is answer B. Now, while massive randomized trials have absolutely proven that breast-conserving therapy like a lumpectomy paired with radiation gives you equivalent long-term survival compared to a total mastectomy, you cannot just throw out the scalpel entirely. Every standard curative pathway for early invasive carcinoma literally mandates surgical resection of the primary tumor bed. Substituting neoadjuvant therapy and radiation while completely skipping surgery, that is just not an established treatment strategy. Let's keep the momentum going with question 1. What is the most common histopathologic malignancy encountered across tumors of the oral cavity, pharynx, and larynx? Are we looking at A, adenocarcinoma, B, squamous cell carcinoma, C, mucoepidermoid carcinoma, or D, adenoid cystic carcinoma? The answer is B, squamous cell carcinoma. Literally over 90% of all malignant head and neck tumors originating in these regions are squamous cell carcinomas. Historically, of course, these are heavily linked to tobacco and chronic alcohol use, but increasingly we're seeing them driven by high-risk human papillomavirus, or HPV, especially right there in the oropharynx. Which brings us nicely to question 2. High-risk HPV-driven oropharyngeal squamous cell carcinomas are clinically very different from your traditional tobacco-induced ones. So, which of the following statements is true regarding HPV-positive oropharyngeal cancer? A, it's associated with a much worse long-term prognosis. B, it characteristically affects older patients with a heavy smoking history. C, it demonstrates an improved response to radiation and chemotherapy. Or D, it rarely metastasizes to regional neck lymph nodes. And this brilliantly illustrates why the correct answer is C. It's a real clinical paradox, honestly. HPV-associated tumors typically show up in younger folks who often don't even smoke. But here's the crazy part. Despite frequently presenting with early cystic nodal metastases in the neck, these HPV-positive tumors display an incredibly excellent response to chemo and radiation. That translates to significantly higher survival rates compared to the traditional smoking-induced cancers. Okay, let's look at question 3. We've got a 55-year-old guy with a painless, firm, slow-growing 3-centimeter mass right in his left parotid gland. An FNA biopsy suggests a benign epithelial tumor. What is the most common benign salivary gland tumor, and what's its classic management? Options are A, Werthin's tumor with enucleation alone, B, pleomorphic adenoma with superficial parotidectomy and facial nerve preservation, C, mucoepidermoid carcinoma with radical parotidectomy, or D, oncytoma with observation. The correct choice is B, pleomorphic adenoma, also known as a benign mixed tumor, is the absolute most common tumor affecting salivary glands. Now, because of how closely the parotid gland sits near cranial nerve 7, the facial nerve, simple enucleation is strictly contraindicated. Why? Well, these tumors have this incomplete pseudocapsule. If you drop even a few cells during a simple enucleation, it can lead to extensive, multifocal recurrence. Nobody wants that. So the gold standard is a superficial parotidectomy while painstakingly dissecting and preserving those facial nerve branches. Instantly transitioning to question 4. When we're managing malignant salivary gland tumors, which specific histopathological subtype is the most common primary salivary gland malignancy found in both adult and pediatric populations? Is it A, adenoid cystic carcinoma, B, acinic cell carcinoma, C, mucoepidermoid carcinoma, or D, carcinoma x pleomorphic adenoma? It's C, mucoepidermoid carcinoma. This one takes the top spot for frequency across all age groups and shows a really variable biological behavior, grading anywhere from low to high malignancy. Compare that to adenoid cystic carcinoma, which is notorious for having a totally different biological profile. That one is indolent but relentless, marked by extensive perineal invasion and late distant metastases to the lungs. Moving right into question 5. Picture a 62-year-old chronic smoker who comes in with a progressive, painless 1.5 centimeter ulceration on the lateral border of his tongue. Biopsy confirms squamous cell carcinoma. Scans show a clinically node-negative neck, or CN0. What is the appropriate initial surgical management? A, wide local excision alone. B, radical radiation without surgery. C, wide local excision paired with an ipsilateral selective neck dissection. Or D, total glossectomy and bilateral radical neck dissections. Now, what's really interesting about this slide is that the answer is C. Even when the neck feels totally clear clinically, early-stage oral tongue cancers have a massive rate of occult, microscopic lymph node metastases. We're talking over 20 to 30%. Because of that hidden risk, standard practice dictates that you pair the primary wide local excision with an elective, selective neck dissection. Typically, you're clearing levels I through 3 to manage those micrometastases and ensure accurate staging. Let's test some pure anatomy with question 6. During a neck dissection, which lymph node level specifically describes nodes located within the anterior triangle, bounded by the hyoid bone superiorly, the suprasternal notch inferiorly, and the lateral borders of the sternohyoid and sternothyroid muscles? Is it level 2, level 4, level 5, or level 6? That exactly describes level VI, making the answer D. This is your central or anterior compartment. Think of it as a central pocket nestled right between the hyoid and the sternal notch, and it houses the pretracheal, paratracheal, parathyroidal, and precricoid, also known as Delphian lymph nodes. Question 7. A 48-year-old female presents with persistent, unilateral, clear nasal discharge that gets noticeably worse when she bends forward. She also mentions a strange metallic taste. Fluid analysis comes back positive for beta-2 transferrin. What does this confirm, and what's the primary risk if you just leave it unmanaged? Is it A, allergic rhinitis and asthma? B, CSF rhinorrhea and high risk of ascending bacterial meningitis? C, chronic sinusitis and orbital cellulitis? Or D, sialolysis and salivary atrophy? The absolute giveaway here is the beta-2 transferrin, meaning the answer is B. That marker is highly specific, literally pathognomonic for cerebrospinal fluid. This patient clearly has a CSF leak through a skull-base defect, which is exactly why the clear discharge worsens with gravity. The absolute primary risk here? You now have a direct open line of communication between the upper aerodigestive tract and the intracranial space. That carries an exceptionally high risk for ascending bacterial meningitis. All right, for our final clinical scenario, question 8. Which of these head and neck conditions is considered an absolute emergency requiring immediate airway management rather than standard outpatient tracking? A, unilateral vocal cord paralysis presenting as stable hoarseness. B, acute epiglottitis presenting with stridor, drooling, and a tripod posture. C, a stable 1 centimeter thyroglossal duct cyst. Or D, stage 1 glottic carcinoma without respiratory distress. The answer is definitely B, acute epiglottitis. A swollen epiglottis severely narrows the airway and is a true emergency that can cause rapid, complete upper airway occlusion. If you see the classic triad, stridor, drooling, and a tripod posture, where the patient is literally leaning forward just to physically optimize their airway, that indicates impending airway failure. You must achieve airway stabilization immediately in a controlled OR or ICU before you even think about secondary diagnostics. So, with things like HPV-driven cancers and BRCA mutations completely redefining our treatment paradigms across the board, the big question remains, how will your surgical practice adapt to this new molecular age of pathology?